Hello, everyone. It's great to be here today. I'm going to give some summary of the updated recommendations for SARS-CoV-2 vaccination. I've been a clinical investigator for a number of clinical trials funded by industry, but I personally don't have any financial interest in any pharmaceutical company. In the last 3 years, we've given about 13.5 billion COVID-19 vaccines. This map is showing the share of people who've received at least one COVID vaccine in that period of time. And most of the world has gotten, 60 to 70% of their population vaccinated. But that still leaves really large groups of people that actually never received a vaccine. So, for example, in Nigeria, over 100 million people never got a vaccine. And in India, where there's actually comparably good coverage, still about 378 million people never got a vaccine. COVID-19 vaccine types also vary significantly across the world, and mRNA is not everywhere. This is a figure I made a few months ago that shows just the number of vaccine doses by type in some select countries. So in the United States and in the European Union, we've given 1.5 billion or so, $1.5 billion vaccines, and most of those have been mRNA. In South Africa, it started out as J&J and now recently mRNA. But in India, absolute numbers, over 2 billion doses, and almost all of those were AstraZeneca, which is an adenovirus-based vaccine. In that first year, COVID-19 vaccines have been estimated to have prevented over 20 million deaths, really, globally during that period of time, and they've continued to provide protection. Most of that protection was to the benefit of high-income countries and upper-middle-income countries, since those are the places that actually received the vaccines during the first year. But 2020 is not 2023. Things have changed, and most of the world has some immunity to COVID-19, either from vaccination or from infection. These are a bunch of graphs that I pulled out from representing overall seroprevalence, meaning, general antibodies to COVID. And I'm showing for global seroprevalence, for high-income countries in the Americas, and then for African countries. The top figures are overall seroprevalence, and the bottom figures is seroprevalence induced from infection. So globally, we're now getting to about 75% of the world has some kind of pre-existing immunity to COVID. About 25–30% of that was from infection. In the Americas, in high-income countries, it's now about 100% of people have some immunity to COVID-19, but only a small fraction of that actually came from being infected. In contrast, in African countries, also the seroprevalence is getting close to 90+%, but almost all of that was from having been infected. So since the beginning, the problem and the challenge for COVID-19 vaccines has been the evolution of SARS-CoV-2. In the beginning, we had our ancestral or Wuhan strains that were circulating, and that's what was in our vaccines, and that's what we tested them against. But by the time we were actually rolling out those vaccines, we already saw the emergence of Alpha and Delta variants that were increasingly immune evasive. And then in early 2022, we saw the emergence of Omicron. And we've actually had Omicron strains and subvariants since then. However, these have also now generated new subvariants of Omicron. And that, even when we updated our vaccines to BA.5, we then got even more Omicron subvariants circulating. These days, our current variants that are circulating are XBB.1.5, and then more recently, EG.5.1. And Omicron diversity is increasing. This is a SARS-CoV-2 phylogenetic tree. Each branch of this tree is showing the genetic distance between these different viruses and their variants. Up at the top right of this figure are the original strain and then those early variants of concern, beta, alpha, and delta. And then on the left side, you can see these big long branches of increasing diversity of Omicron. And I've highlighted in the dashed boxes a couple of these subvariants to note. One is XBB.1.5. That's what's in our new 2023 vaccines. EG.5.1, which is what's circulating now and picking up speed. And then of note, BA.2.86, which is down at the bottom in green. It hasn't made a big splash yet, but it's notable because of how long that branch is. It has a lot of mutations, so people are keeping an eye on it. So with this evolution, we've also tried to update our vaccines, and but with limited success. So on the left are all the ancestral or Wuhan-based vaccines that are authorized by either the World Health Organization or the EU, US, and they include a whole bunch of different styles of vaccines. However, our subtype-specific vaccines have been much more limited, and the only vaccines that include an Omicron strain are mRNA-based vaccines. So either the bivalent, including an Omicron plus Wuhan, or monovalent with just an Omicron. So what I put in the box here is what we can consider the 2022-2023 formula. That was the bivalent with the Wuhan strain plus the BA.4/5. And then these days we have our updated 2023 formula, which has the XBB, just XBB in it. Again, only authorized Omicron-specific vaccines are mRNA-based vaccines. And I just keep highlighting that because if you remember, mRNA is not everywhere. And even though it's increasing in distribution, it's still not everywhere. And so these vaccines that I'm talking about, these updated vaccines, are really mostly conferring benefit to high-income and upper-middle-income countries. Of note, the Novavax recombinant protein-based vaccine, they have updated it to include XBB, and that's currently under FDA review. If that is approved, that would be the only non-mRNA vaccine with an updated strain. So when we rolled out this updated vaccine last year, how did we do? And we actually did pretty well. The vaccine did improve vaccine effectiveness against all COVID-19 related outcomes. This figure is from this recent CDC presentation, and it's showing in particular the vaccine effectiveness against emergency room visits or urgent care visits. So up at the top is our unvaccinated cohort, and then we have in the first box protection conferred by just having received the primary monovalent vaccines. And I point this out to show that there's really very little protection that these vaccines are still giving us. For the oldest cohort, they are getting some protection against ER visits and worse outcomes, but we can really improve that, and we did by giving that bivalent booster. So the second box is showing improved vaccine effectiveness over 60% for all of the age groups, and I point that out because you'll see the CDC is recommending the vaccine for all age groups for which it's approved. And part of that is because you can see that it is protecting even kids from presenting to urgent care visits. That vaccine effectiveness starts to wane even after 2 to 3 months. But in total, in real world vaccine effectiveness studies, that bivalent updated boost provided 4+ months of increased protection in all ages. In addition, the vaccines remain exceedingly safe and well tolerated. There are common adverse events, injection site reactions, non-severe fatigue, headache, and fever and chills. And then there are rare but serious associated events. And these are good to know about because your patients will come to you asking about these. So the 3 main ones are myocarditis, which has been mostly observed with mRNA vaccines, possibly with recombinant protein. There's about 10 to 100 cases per million doses, and it's mainly in young men. So the 100 cases per million is in young men. Mostly self-limited, a couple cases make it more seriously into the hospital, but in general, pretty mild. And then you have thrombosis with thrombocytopenia, and that's been observed with the adenovirus-based vaccines, about 4 cases per million. And then Guillain-Barré syndrome has been noted with also the adenovirus-based vaccines. This one, we're still not quite sure it's really associated with it, but it's been observed about 3 cases per million doses. So we rolled out that new updated vaccine with the BA.5 insert. Well, how did it do against the new 2023 variants? Because I told you it evolved from BA.5 to include XBB and even other ones. So here's some immunology that was done by my colleagues at Beth Israel Deaconess, really where they asked the question in some participants that had received the bivalent boost, how are their antibodies doing against the new variants. So before the boost, there were some pre-existing immunity to BA.5 and the new variants, likely conferred from either previous infection or the primary series. 3 weeks after getting the bivalent boost, they had a nice bump in responses, particularly to BA.5, which makes sense because that's what was in the vaccine. So that's a match. And some improvement, but not wild improvement to the new variant. And then that all kind of drifted away by 6 months. So looking at this data, it didn't look great. It looked like the bivalent vaccine increased antibody responses against BA.5, which was the match, but less so against XBB, which was a mismatched variant. However, in the real world, that didn't play out in that negative way. It actually looked much better. So in the real world, with vaccine effectiveness, observational data, it looked like the bivalent BA.5 updated vaccine from last year protected against hospitalization when the matched variant was circulating, BA.5, and when the mismatched variant, XBB, was circulating. So that's in the bottom part of this figure, showing vaccine effectiveness up to 60% against hospitalization, even when XBB, the mismatched strain, was circulating. And I'm pointing this out to say, or observe, I think we're always going to be in a situation where our COVID vaccines are a little bit mismatched with the variant that is currently circulating. And that just seems to be the pace of how they change. So how our vaccines perform in the setting of a mismatch is very important. And this is what I'm trying to emphasize here, is that last year's updated booster performed very well, even when the circulating strain was a bit of a mismatch. So despite the fact that the vaccine did very well, nevertheless, unfortunately, there was low uptake of that vaccine in the US. So as of May of last year, only about 43% of the most vulnerable population, those over 65, actually received that updated bivalent vaccine. And these were some of the reasons that people gave for not getting that vaccine. So one of them was that they'd already been infected at least once. They were worried about side effects. They didn't think the booster will add more protection over the vaccines that they've already had. They were worried about the safety. They didn't think it would protect them from severe disease or death. I'm hoping with this particular presentation that you will have some of the answers to give to patients who come up with these reasons, because we want to be able to answer these concerns. So now we have the new updated vaccines. I was talking about last year's. Now we're talking about this year's, which is 23-24 formula. That's what the CDC is calling it. And this is data presented from Pfizer at that CDC meeting, looking at immunology. So we don't have any efficacy data. This is just what immune responses in humans were generated with this new vaccine. And here they compared it to the original vaccine, excuse me, the bivalent vaccine, versus the new updated vaccine, showing very nice, robust immune responses to both XBB and to the newest circulating strains that are currently out there right now. And then Moderna also showed similarly that their updated XBB vaccine elicited big boost in antibody responses against the XBB strains and the most recent currently circulating EG.5.1. And they showed that this was true in people who already had prior infection. Remember, that was one of the reasons people were hesitating about getting the boost. Here they're showing even if you had prior infection, this is going to raise up your immune responses. Novavax also presented some data. As I mentioned, their updated vaccine is under FDA review. This is very kind of preliminary data. First of all, it's only in macaques, which are non-human primates, and only at day 14 following immunization. But they too are showing that their updated vaccine boosts up XBB specific responses and also against the newer variants. And the reason why we care, why are we trying to get these vaccines out there, is because of observations like this, which is an epidemiologic curve of hospitalizations showing the rise in hospitalizations this month for those who are over 65. And there is a bit of a rise actually for all of the different age groups, but most steeply for those who are over 65. And the economists can put a bunch of things in their pot and stir it up and analyze, the rates, expected rates of various cases or hospitalizations in different age groups, factoring in the potential benefit from the booster, factoring in the potential side effects. And from that, they made these estimates of cases averted. So in those who are 65 years old, the booster, if you give a boost per 100,000 individuals, you can avert almost 9,000 cases, 391 hospitalizations, 84 ICU admissions, and 43 deaths. So this is what led to the current US CDC recommendations, which endorse vaccines that are updated with the 2023-2024 formula. They recommended that all individuals 5 years of age or older should receive the monovalent XBB vaccine, and that individuals with immunocompromising conditions and adults over 65 can consider getting additional doses of the vaccine later in the year. For those who are 6 months to 4 years old, really depends on what the previous vaccine history is. Those prior vaccines, the monovalent Wuhan vaccine, the bivalent mRNA vaccine, none of these are recommended anymore or available. And so for people who are 12 years old or older who cannot or choose not to get an mRNA vaccine, they do have the option of getting the Novavax vaccine with that original Wuhan strain. And then hopefully soon that might be updated with the XBB strain. So in summary, COVID-19 vaccines, the primary series saved 20 million plus lives, but protection waned over time and against Omicron subvariants. The 2022-2023 bivalent Wuhan Omicron booster improved protection against COVID-19 outcomes, even when there was a strain mismatched, and increased immune responses even in those with previous infection. The vaccine was safe and well tolerated. The updated 2023-2024 vaccines contain only the Omicron XBB strain, and immune responses suggest that cross-protection against circulating strains will occur. And vaccine acceptance and equity of distribution really remain critical issues. Thank you very much.